And I had to take it down because all I can see is the dark venous pooling under her eyes and the fact that her mouth was always kind of propped open like this, whether she was smiling or at rest.
The difference is ultimately speed. CO2, since its wavelength is higher, penetrates deeper and faster.
You're not a complete dentist without learning airway.
But our goal at the end of the day is to treat these issues long-term, not treat the symptoms that are happening right now.
Welcome, I am Lauren Gates, and I am your host of this evening's Airway Health Solutions Masterclass, and we're so excited. It's What's the Buzz About Laser Therapy, Unlocking the Power of Light in Airway Dentistry, and we have our fabulous panelists with us who can share firsthand their experience on incorporating laser dentistry into their offices. We have Dr. Andrew Cohen, we have Dr. Piya Gandhi, and Dr. Jenna Schwibner. So thank you all for joining us. And they're going to be sharing how they successfully use laser technology in their practices. And I thought it was such a hot topic, and everyone always asks about it. And I know at Airway Health Solutions, we always recommend laser therapies in our protocol. So just wanted to bring it all together and actually celebrate our partnership with Light Scalpel. So we're very grateful for them this evening for also helping us and working in the future with them to bring more education like this to you so you can get your questions answered and help your patients when laser therapy is needed. So I would love to just go around the horn casually here, just like a quick intro. I'm going to read your bio, so I'll get all that out. But let's just start like with Dr. Cohen. If you just want to introduce yourself, what kind of dentistry you practice, where you practice, and maybe just something that we don't know about you.
Hi, everyone. Andrew Cohen. I practice outside Philadelphia in the suburbs, diehard Philly fan, across the board. I am a comprehensive restorative dentist with a huge passion for sleep dentistry because it's my own personal problem. I was diagnosed with sleep apnea in 2012, and I'm looking forward to sharing my story of fixing myself in the last 13 years.
Wonderful. We look forward to it, and thank you for joining us. Dr. Gandhi, you want to tell us a little bit about yourself, please?
Yeah, I'm Dr. Piya Gandhi. I am originally a New Yorker, but have been in the Houston area for the last 15 years. I practice functional pediatric dentistry here in Houston. And when I'm not practicing dentistry, I love to cook and do yoga and spend time in the mountains.
Lovely. Okay, and Dr. Schwibner, tell us a little bit about yourself.
Hi, I'm Jenna Schwibner. I'm a general dentist in Vero Beach, Florida, which is where I grew up. I was born in New York, but grew up here. And after graduating dental school, moved back here to partner with one of my best friend's parents. And it was a private practice, and doing general dentistry, and transitioned the practice to me personally. I have a partner, but me personally doing mainly probably between 70 to 80% of what I do now is just airway. Orthodontics, a lot of orthodontics, tongue ties, and utilizing lasers for that. Something about me is I am BRCA1 positive, meaning I have over 80% chance of getting breast cancer, ovarian cancer. So I had 9 surgeries over the course of 6 years from 2016 to 2021, preventative surgeries to keep myself from getting cancer. So to me, prevention is better than reaction. And I take that every day with my patients as well when it comes to sleep, because I feel like if we can work on the younger kiddos and even the adults that don't have apnea, I always kind of say yet, because as we break down, we're more prone to it. So how can we help our patients prevent that end stage disease of apnea and have them be healthier instead of just surviving after the fact? And that's what I did for myself with cancer. And that's what I hope to do for my patients with breathing.
Well, thank you for sharing that. And we are thrilled to have everyone here and I can't wait to hear your stories and really get to know how you've helped people breathe, sleep, and thrive. Everyone's commenting that they're grateful for this call, and we thank you for your time and sharing your stories with us. Let's see who's with us tonight. We're going to go ahead and launch that poll and see what type of professionals are joining us. So if you want, you can also put in the chat if your profession isn't listed. If you want to share in the chat where you're from, I'm always curious about that as well. So I'll give it a couple of minutes. We have about 50% participating. And let me just scroll down and see all these other options. Okay, other healthcare professional. I would love to see that in the chat. We have a parent here, so welcome, parent patient. Okay, I'm going to go ahead and almost close it. Let's see. Okay. Let me share the results. So there we go. So we have a nice mix here. Dentists are in the lead for this call. So we welcome everyone and we're thrilled you're here. We really appreciate your commitment to oral health, to airway health, to your patients' comprehensive health. So thank you for being part of the healthcare team for your patients. And again, we'll show up as much as you show up to offer these types of webinars. I do have some housekeeping items to share. Number one is we are thrilled to offer a free fundamentals airway course with a raffle at the end. It's a $700 value, but you do need to be present to win it. So you got to be in it to win it. And we're also excited to offer flash sales to our attendees who are in attendance, up to $1,000 in savings at the end. So stay tuned for the codes at the end of the master class. And as far as CE goes, there's no need, no code. We will just see by the attendance report from Zoom that if you were here, it logs on your attendance. So we will send you the CE certificate automatically if you're here for the entire time for your CE hours. And I'll just do a quick disclosure and try to read it as fast as I can. Is the following presentation is provided for educational informational purposes and only, and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease. And those seeking personal medical advice should consult with a licensed physician or dentist and always seek the advice of your doctor or other qualified health provider regarding a medical or dental condition. Okay, so I think I have my part covered. You can actually, if you have questions, we're going to have it where we're doing 3 presentations, and after each presentation, we'll have room for Q&A, time set aside for you guys to ask your questions. So while the doctors are speaking, feel free to put them in the Q&A box, and we will answer them as we go. This way they're fresh in your mind, and we can get your answers answered right away. So, okay, we're going to start with Dr. Cohen tonight. Sorry, Dr. Gandhi tonight. I apologize. I made you nervous there. We're going to start with Dr. Gandhi. So why don't you go ahead and share your screen, and I will read your formal bio while you do that. So Dr. Piya Gandhi has been practicing dentistry since 2009 and completed her pediatric specialty training at the University of Texas in Houston. Her practice is inspired by her role as a mother of her 2 daughters, Sierra and Ayana. Dr. Gandhi emphasizes the critical role of breathing and airway function in oral health, and her practice offers a range of services from routine checkups and dental cleanings to advanced screenings for airway and oral disorders. Beyond her residency, Dr. Gandhi has pursued extensive training in airway development and the diagnosis and treatment of tethered oral tissues. She routinely screens her patients for airway disorders and other oral restrictions that may impact growth, development, and healthy sleep. She's going to tell us a lot about her during this presentation. So I'm just going to go ahead and hand it over to Dr. Gandhi. Welcome and thank you.
Thank you so much, Lauren, for having me tonight. I'm just going to give you a little glimpse of why I do what I do and the impact that it can have, not just on yourself as a practitioner, but on all the families that you treat. There's a lot more to this, but tonight is just to share the why behind what we do. So just starting out with a quote here. When a child struggles, a parent doesn't stop searching until they find the why. And I have parent after parent that come into my practice seeking answers that they haven't been able to find from any medical professional that they've been to. And they just don't stop until they get what they need. And, I experienced this firsthand as a mother. This is Syra, my older daughter, a little over 12 years ago. And, I look at this picture and it brings back a lot of great memories, but it also just reminds me of a time that was such a struggle for me and my family. Obviously, I was a first-time mom. I was actually a general dentist at the time. And I had a lot of plans for our first year of life together, even just our birth process. And from the get-go, Syra was born a little under 36 weeks, not because she came naturally, but because she was too big and they decided to induce her. And really now looking back at that situation, I think, I fell sort of victim to some medical conveniences. And she was nowhere near ready to come in. And, now we know, 36, 37 weeks, babies are really just not ready at that point to thrive in this world. So, but, again, you know what you know, and you follow the advice of the people that are professionals in the field. And so we went through a very traumatic birth. I fractured my tailbone and there was, several complications. And even beyond that, the first thing that I thought of was, of course, like our feeding journey and wanting to latch her right away and get that skin to skin time. And all of that, got robbed from both of us because of this traumatic birth. And then when we were able to connect, she did not latch well. She was unable to breastfeed. It was very painful for me physically to try to feed her, but emotionally, it also took a huge toll on us. And I did what so many of my patients do, which is go to the professionals, the lactation consultants, the pediatricians that we spend so much time researching and trying to find the right fit of the people that are going to guide our family's health, and fell short at every stop I went. It was, oh, don't worry about it. Just give her a bottle. She's feeding fine. She's gaining weight. And at no point did anyone ask how I was doing or what kind of toll it took on me not meeting these goals, not being able to form this bond. 12 years later, you can still see I get emotional about it. And it's still happening. It's better, but it's still happening. And even myself being in the dental field, I didn't know any better. I wasn't taught any of these things. I didn't know what a tongue tie was. I didn't know what infant feeding should look like. So I did what I was told. I sucked it up. I gave her a bottle. She was always just a very cranky, colicky baby. Her dad and I would call her the noisy baby, kind of jokingly, but now we know why she was so noisy, because she was very unsettled, very tight, just not functioning well. And so, like so many families that I interact with, we kind of moved on, chugged along through our first year of life. She turned out to be a really cute little infant. And again, I had kind of buried the emotion and the struggle from those first few months of our time together. And then just continued to ignorantly watch my child dysfunctionally grow. And again, not knowing anything about anything, we would go in for our yearly checkups. Everything was fine. And then I decided to go back to residency and become a pediatric dentist. This was when Syra was about 2 years old. And, even in pediatric residency, I learned nothing about tongue ties or airway development or palatal development, when the jaw peaks and how we guide the growth. But I did learn about what a kid looks like when they're not sleeping well from a tonsil and adenoid perspective. And this picture is my niece's and Syra. So she's the one in the plaid. And we got this professional photo shoot done. She was about 3 at this time. And when we took these photos, I thought, oh, she looks adorable. And I had this huge portrait of her in her bedroom from this photo shoot. And I had to take it down because all I can see is the dark venous pooling under her eyes, and the fact that her mouth was always kind of propped open like this, whether she was smiling or at rest. And at the same time, she had started preschool and would come home every day and just melt, like have these epic tantrums that you couldn't reason with her. I mean, it was like she was possessed, and she kept it together at school every day. And again, it brought me back to that feeling as a parent of being totally helpless. I had no idea what was going on. I felt like an awful parent that had no control over their child. Is this bad parenting? Am I like, just don't know how to do it right? Is there something else going on? I also started to hear her audibly snore at night. And from my pediatric residency training, knew that wasn't normal. Her dad's a physician, and I kind of brought it to his attention, and I was like, something's going on, that like mom instinct, something is not right with my child. And he kind of brushed it off until we went on vacation together, and we all slept in the same room, and she kept him up snoring the entire night. And that's when he was like, okay, maybe we should look into this. Well, I had already made an ENT appointment at that point. And coincidentally, she had failed her hearing screening the week before this ENT appointment. So yeah, we were already at the point where her adenoids were so large, she couldn't clear fluid from her right ear. She was 90% deaf out of her right ear. She was audibly snoring. It was clearly impacting the quality of her sleep, but I had no idea about any of this, that all of this was connected. And at the time, I was finishing up residency, getting ready to open my first practice. And I knew I wanted to incorporate laser dentistry, partly because I found it interesting, but also there was no one in my area really doing it. So it was just like the universe brought this to me. And I signed up for a course with Dr. Zaghi. And in that course, he started reviewing the symptoms of a child with airway disorder, tongue tie, lip tie, underdevelopment, of the maxilla and mandible, and everything he said was Syra. And I went home after this course. I actually started crying during the course, thinking, how did I miss this? How did I not know about this? And, luckily I have access to this kind of knowledge because I am a dentist. And so I went home, and this was 2017. So we weren't really focusing so much on interdisciplinary care, looking at tongue space, looking at tongue tone, looking at the overall body. So I looked in her mouth. There was a tongue tie and a lip tie, and I was using a different laser than I use today, but I released her with minimal sort of pre-therapy or overall body therapy. And similar to so many medical procedures, like the wound looked good, the release looked good, but the function still didn't really change very much. And, I had started treating patients as well, mainly infants, for tongue ties. And I was seeing similar things. Some of them were doing great. And some of them, it was just like, what am I missing? And so this was Syra, post first release, but you can see the deficiency. She's in early mixed dentition. She's got, a narrow upper jaw. There's no room for those laterals. Behaviorally, she was doing better. But again, that like mom gut in me was just like, this is still not my child. I still have not seen my full child yet because I'm missing something. So, as a practitioner, but really as a mother, I dove deep and started looking at other things: expansion, chiropractic care, PT, myofunctional therapy. And I spent a lot of time at lectures, but also with local practitioners that dealt with function, and I learned a ton, and it all made sense to me. But it was just crazy that I'm in the dental field and I knew none of this. And I have patients sitting in my chair that need all of this, and no one is talking about it. And my own child is struggling. And so I learned all the things, and then came back to Syra, expanded her. We did extensive chiropractic care. We did myofunctional therapy. I changed my laser. And then I released her again at 7.5 years old. And it felt like for the first time I had met my child. And it was life-changing for me as a mother, but for her as a child, for our whole family. And it totally changed my practice. And so this is her a couple of years ago at Disney, and she is thriving. She has beautifully straight teeth, and I've never put a bracket on her. This is all just expansion work and myofunctional therapy, and the tongue being in the right spot and breathing through our nose. She recently graduated to Point in ballet, and is just doing amazing. And it's, like I said, been totally life-changing for me, and something that, you know, the universe just brought to me because this is what I'm supposed to do. This is my mission in life, is to bring this to other families that are not in dentistry, don't have the opportunity to learn on their own. So our number one mission is education. And even if you don't treat all of it, then screen for it and educate your families on it and find other people, because this is life-changing work. It will change you as a practitioner, and it will change your families forever. So that is my why. Through this process, I have totally changed my lens on how to practice dentistry. So this is called the Function First model. It is what I teach on. It is how we practice dentistry in our practice. So we screen all of our kiddos, whether they're coming for wellness care or not, for breathing disorders, sleep disorders, growth and development discrepancies, feeding disorders, speech disorders. We have a full in-house team of therapists that includes IBCLC, Chiro, Myo, 2 SLPs, so that we can practice in a functional model. So the Function First model looks at the family first. How do we support this family as a whole? Because this is a family issue. This is not just something happening to this child. So we need to know the story. We need to educate the entire family. Who are we partnering with? So we can't do this alone, okay? ENTs, pediatricians. These children are seeing other healthcare practitioners, and we have to loop them in, whether they're fully on board or not. Functional providers are the most important. These are our chiros, our myos, our PTs, our osteopaths, you know, all the people that are working on muscle function that are going to help support these procedures, whether it be expansion or tongue tie releases that we're doing. And then us as the treating provider, understanding more than just how to do a good procedure or how to put an expander in. You know, I love this quote: true healing happens when we connect the dots, not compartmentalize them. So it is about working together in a comprehensive fashion. And it's a process. It is not a quick fix. When we are dealing with root cause, it's never a quick fix. That's a Band-Aid. So these families need to understand that they're signing up for a process, and things will take time. But our goal at the end of the day is to treat these issues long-term, not treat the symptoms that are happening right now. And then lastly, you know, in my opinion, pediatric airway treatment is incomplete without addressing muscle function and tethered oral tissues. So maybe you're an airway provider that's doing expansion and not tongue tie releases, totally fine, but at least screen for them and screen for the myofunctional disorders, and then refer to those who are looking at these things and treating them. And then obviously this has brought me professionally to a totally different place than I had anticipated. Yes, I'm a board-certified pediatric dentist, but the bulk of the work that I do is functional and airway and TOTS focused. But really, this all came from my mission as a mother and seeing my kids thrive and helping other kids live their best life possible. So that is my why. That is why I do what I do. I learned the hard way, you know, that tongue tie is a small piece, but then expansion is another piece and breathing is another piece. So we have to put all these pieces together to really create healthy humans that are going to live to their biggest potential. So that's about me. All the courses that I teach focus on this type of work and how to, you know, assess a child as a whole and bring all the pieces together and work with other practitioners. And that's really what we hope to get into in subsequent courses, is the nitty-gritty of how to bring this stuff to your patients. So thank you for your time. And again, this is a lot of my practice is driven by a parent that just won't give up. And that was me. So thanks for being here tonight. Would love to hear any questions that you have.
Wow. Thank you, Piya. That was really heartwarming. And thank you for sharing from your soul. And God bless you for saving all these children, starting with your own, that mama bear instinct. We do have a couple of questions in the chat. Is which laser did you use and what do you use now and why, Dr. Christensen?
Yeah, so I started with a BioLase, water laser, and I really went for that tool first because I thought I was going to be doing some hard tissue laser dentistry. And that tool just, it didn't work for me in that capacity. And so then I was really only using it for soft tissue procedures, mainly tongue tie releases. And I didn't love the quality of release that I got with that specific erbium laser. So I switched to a light scalpel. I used the water laser for about 18 months. And then I switched to light scalpel and I love it. I've never looked back. I have 2 of them. I have 1 for each of my practices. And it just, the healing is tremendous and the precision and it is really an incredible tool. I don't think I'd use anything else.
Thank you for sharing. Let me see if there's any questions in the chat. Yeah, here we go. Do you have a database on ENTs that understand this or places we can refer our patients? All of mine in my area are pretty dismissive. Any recommendations on that?
That's a really tough one. I'm in the 4th largest city in the country and I have 3 ENTs that I refer to. And it's something that, we have to continue to work on. My philosophy with practitioners that are not on board is not to ignore them, but respectfully educate them. And so unfortunately, you have to find your 1 or 2 gems or someone that's willing to just listen and try to convert them. But I don't have a database. I don't know one out there. If I ever find something, I'll be happy to share it. But our medical professionals are still kind of far behind on this type of treatment. And so what I would say is, parents are the best advocates. Empower your parents to push their providers to do these things.
Yes. This quote, behind every healed child is a parent who refused to give up. Is that your quote?
It is just something like I not those words, but in many different ways I've said this. But yeah, I mean, it is that truly is what it is we're all this field, I really believe is parent driven.
Not only that, though, if you think about it, behind every child who's breathing who wasn't before and they were treated by airway healthcare professionals, you could substitute that in for the parent as well, because we have to, if we can prevent this, that's wonderful. But if we can't, we're so grateful to all the airway dentists, myofunctional therapists, all of the healthcare providers out there who really make a difference in the trajectory of a child's life. She just wanted to make sure she credits the right person when she shares it. That's all for the quote. So
yes, then yes, yeah. I mean,
okay, wonderful.
Okay.
Random question: do you have to use anesthetic for your releases with your new laser, and how about post-op pain?
Yeah, so I do use anesthetic. I mean, it depends on the age range. So for infants and awake toddlers, I just use a topical numbing. And really it's, I don't really feel it's necessary for the infants because it's so quick, but the reason I do it is because I suture my infants as well. So I really use it for the suturing process. But on older kids, and I do use local anesthesia, but honestly, it's really, really little because we're doing functional frenuloplasties, which means they are actively moving their tongue during the release. So I can't make them so numb. So it's a very superficial infiltration that wears off about 20 minutes after the procedure. So it's just lidocaine. We're not really anesthetizing. It's really not necessary. This is not a heat-based laser like a diode. So it's totally different. It's irritating, but it is not that heat-based pain that we see.
Thank you. Do you have a referral program for children with DS? I am in Texas Panhandle area. Hard to find people to work
Sorry, in terms of finding a practitioner near you?
Yeah. Mm-hmm.
I mean, if you reach out to me, I don't have like a database, but I know a lot of practitioners. And if I don't, we're part of a lot of groups that we can usually find someone relatively close. However, I will say I have patients that travel hours to see me that we treat remotely. And we do sort of remote consultations. But if we can find someone close to you, then we would prefer that you to have a provider close by. So just reach out. Lauren can share our
Sure.
practice
Yeah,
information.
you can reach out to me, Diana, and I will follow that up with that. Are there ages that you wait on frenectomies, or you do it at any age?
Most of the time, the majority, we are not waiting. The only exception, so a lot of people won't treat the toddler age. And some of that depends on what you have access to. So as a pediatric dentist, I'm very comfortable with sedation. So if we need to utilize that, the biggest thing about the only reason we would not do a release is if we don't have enough space in the mouth and we don't think we're going to get a good outcome. Or if the parents and the therapists are really struggling with pre-therapy, whether it's manual stretching or compliance with myofunctional stretching and myofunctional exercises. That's a very important part of success, is the muscle being ready and the child being ready and the family being ready. So readiness is a big, big deal. Delaying a procedure for an infant a few weeks or for an older kid a few months to get ready is better than rushing into a procedure. But no, I treat every age. I'll do awake toddlers till about 20 months, big kids swaddle. But again, I'm a pediatric dentist. That is not for everybody. But yeah, there's no real age, blanket age that I won't do.
Right. And why do you suture the infants? Isn't stretching from the parents minimum 3 times a day enough for proper healing?
So I tend to do more stretches than that, but it's the same concept of why we do sutures on kids and adults, primary wound healing. It also, what our protocol is that if we do suture an infant, similar to the kids and adults that get sutures, we delay the start of stretching for 2 to 3 days, which is awesome for parents with infants because they don't have to get in the mouth right away and start doing things. And so we bring them back a couple of days later, go over stretching, and then they are able to really grasp that concept.
Let's see. Do you ever wait to treat lip ties?
It depends on function. Yeah. I mean, sometimes all of it depends on function. So whenever we're doing a assessment of whether a tie, lip tie, tongue tie, cheek tie needs to be released, it's not just looking at the anatomy. You have to look at functionality, range of motion. This is where therapists really come in to look at the details of that. That's where, as a release provider, you're doing what we call a 3-part assessment, which we dive into in our other courses. So there's a lot of nuance to release, not release, timing of a release. And so, yeah, it just depends on function. So sometimes we wait, sometimes we don't.
What are signs and symptoms that we can screen for to know if a child may have issues with airway and breathing outside of the clinical exam, such as things we can ask parents or things parents commonly report?
Yeah, so the golden rule for pediatric sleep is children should be silent and still. So asking, like, not just are they snoring, because some people just think that means loud snoring or, something really audible. No, I mean, is their mouth open or closed? You can even see this on a clinical exam. What are they doing in your chair? Are their lips chapped? A lot of parents will report grinding because it sounds horrible. Movement in the bed. So what does their bed look like when they wake up? Are there sheets all over the place? Are they upside down? Those simple things that a lot of parents will find cute. Oh, he's so cute. He like rolls off the bed, they don't even know that that's like not normal. So we have our families bring in videos of their kids sleeping, not so much so I can see it, more so they can see what's happening. And then when I ask them questions, they realize, oh, wow, that is actually happening. And I didn't even know that was abnormal. So mouth open or closed is an easy one. Do you hear anything? Is an easy one too. And what does their bed look like?
Do you have any interesting observations of data for outcomes as you've changed protocols over the years?
So when I started doing specifically tongue tie releases, I did not have this function first model. I treated it very much like a medical procedure. You see a tie, you release the tissue, and then the function is supposed to be good and adequate. I have a lot of data that I have done no stats on, but I will say once I incorporated the functional providers, specifically on the infants, bodywork, chiro care, I can predict what I'm going to walk into at a 2-week post-op. All parents report baby is doing so much better. They're happier. Maybe their feeding's not perfect, but we're moving in the right direction. And at one point when I had done about 1,000 infant releases, we did do, we had a post questionnaire and we did analyze it, and success, meaning significant improvement that the parents were deemed, yes, I'm happy with the outcome, was about 98%. Since then, I'm now close to 6,000 releases. So the process has only gotten better. And I would love to have someone analyze all this data that I have, because we still do post questionnaires. But we're just trying to treat the kids at this point. And so there's not much room for research right now.
Do you require all families to return for post-op checks, even if they travel several hours plus to your office?
So we will do some of it virtually. If it's feasible for them to do that first check in person, that's great, because I am assessing healing and seeing if we need to course correct anything. But what's nice is we partner with a lot of therapists that are not near us also, and they know what they're looking at. So a lot of them will do post-op virtually. They'll send us photos and then I'll do a FaceTime because it is unrealistic that they're coming back in person.
Well, we're out of time of this Q&A session, but we'll have time to catch up later if you have more questions for Dr. Gandhi. Thank you so much. That was really wonderful, and we really appreciate all you do. So now, if you could just stop sharing your screen, and then Dr. Cohen can take over, and I'm going to go ahead and give Dr. Cohen a formal bio read. So here we go. Dr. Andrew Cohen is a restorative dentist just outside of Philly who specializes in dental sleep medicine. He's educating the profession about the benefits of treatment centered around both metabolic and anatomic options, enhancing outcomes for the sleep disorder patient, providing solutions that positively impact their lives. Dr. Cohen graduated from Syracuse University in 1994 with a BS in psychology, and 4 years later, he received his DMD from Temple University of Dentistry. He completed his general practice dental residency at Abington Jefferson Health and earned a diplomate status in dental sleep medicine from the ACSDD in 2019. As a top dentist in Jenkintown, Dr. Cohen is renowned across the country for his specialty lectures on sleep disorders, case presentations, photography, comprehensive exams, and in 2011, Dr. Cohen was appointed visiting faculty at Spear Education as the moderator of their online dental forum, Spear Talk. All right, well, Dr. Cohen, I am so excited for your presentation because I know you also have a story, everybody does, and we can find out a little bit about your why, and then more importantly, what you're doing about it. So welcome. You just unmute, you're on mute.
Okay, here we go. My practice is mostly adults, so the way that I work through them is really a lot differently because I don't see many kids. So by the time I get to them or they come to me, they're pretty sick people. And we have to understand that there's a lot of options. And not everybody wants to do expansion. Not everybody wants to do orthodontic surgery. Not everybody wants to do CPAP. We have to find out what patients are willing to say yes to. So I'm going to share my story with you and see if kind of work through the process of where I was and ultimately where I'm now and how I present treatment to my patients. So my entire life, I battled daytime fatigue. This became a bigger issue as I entered my 20s. But I always thought it was because I work hard and I had young kids. I mean, who would have thought it was possible to fall asleep in the show Cirque du Soleil in Vegas? But I did. It wasn't until 2012 that I realized I had sleep apnea, and I've spent the last 13 years trying to fix myself. My goal is to optimize my health and improve the quality of my life. Today, my goal is to help you better understand how you can help your patients and maybe yourself. So all the photos you see are mine from spots around the globe. The next slide, you'll see my Instagram information if you want to reach me. My passion to treat sleep disorders began when I made my first snoring appliance, and for the first time, the fog lifted. Over the next 13 years, I learned many new concepts. I changed my approach to treatment, but I always strive to learn more so I could help my patients and colleagues learn how to optimize their health and improve their sleep. I had a lot of help along the way, and my goal was to share this journey with you all. So I love going to work and educating patients about sleep. As a matter of fact, I think as I start to enter my twilight of my career, I want to really focus just on airway and sleep issues. I'm dedicated to learn more and provide customized treatments that fit each patient's desires and needs. I want to help more people say yes to treatment. In doing so, they'll achieve better health, longer life, and a greater well-being. My passion is helping patients optimize their health. However, it seems like healthcare has become what medications or what procedures you can do. The art of listening, prevention, and ideal care has been ignored for the quick fix. But at what cost? Start with Why by Simon Sinek is one of the books that greatly influences me and my staff when presenting to patients. It's the principal foundation of how we deliver care each and every day. Most practitioners talk about a procedure or treatment options with patients instead of helping them first by explaining why their issue or concern needs to be understood and addressed. We can make a much greater impact with our patients when presenting a why first. This is the purpose behind how and what we need to do. It creates an emotional tie, which is a much greater motivator for patients to say yes. I personally found it's the best way to help patients begin the process of owning their health and finding solutions. So my why today is assisting you in discovering multiple options for your patients who need your help. Education is how patients can understand their problem, and the what will be the various treatment options available to help them overcome their health issues. In doing so, they'll improve the quality of their life, optimizing their health. I found the best way to help patients become accountable is to show them, don't tell them. Using the power of photography and 3D imaging allows for co-diagnosis and better communication. Until a patient is aware they have a problem, they don't have a reason to desire a solution. Until a patient understands what will happen if no treatment is performed, they may not desire treatment. And explaining the benefits of treatment, in this case optimizing health, as opposed to risking disease by doing nothing. So the first step, you have to know what to look for. The second step is understanding how that fits into your practice vision. So there's a spectrum of sleep disorders, from snoring to UIRS to obstructive sleep apnea. The net effect, if you go to the right, your body's is unable to get the benefits of sleep, which is repair and recovery. So you suffer mentally, physically from poor sleep quality. And the longer this happens, the sicker people get. And that shows with disease. However, this paradigm is for those who already been diagnosed. We need to find patients earlier. This is how Stanley Liu shows we should look at the paradigm now. We have a window to help patients anatomically and metabolically. If we don't, the progression of disease continues and it will end in more serious disease. The choke point is anatomic, and imaging can help visualize skeletal constriction, deviated septum, soft tissue impingement, and issues at the joint level. Sleep issues can be due to the bones being in the wrong place. During the day, we compensate. However, at night, we lose that ability and our soft tissue gets too close together or closes off. Sharing 3D imaging and photos is the best way for patients to understand and ask for help. You can't unsee it. So the next 5 slides are my CBCT in 2019. If a patient can't breathe through their nose, they're forced to mouth breathe. As a dentist, we see the negative effects of mouth breathing: high caries, dry mouth, periodontal disease and inflammation, skeletal changes and tooth wear. Patients are giving us a sign there's a bigger issue. Airway volume is a predictor for sleep disorders. I explain to patients 150 millimeters is a jumbo straw, 100 millimeters a regular straw, and 50 millimeters a coffee straw. But then I remind the patient, we took this image with you sitting upright. What happens when you fall back, when you lie down and go to sleep? Do you think your jaw can fall back and make this worse? Measuring the soft palate, the length and the width, it's really important in case selection for laser procedures, which I'm going to talk about shortly. I first look at if the soft palate is elongated below the level of the plane of occlusion, and then I look at the length and the width. Transverse dimension less than 32 millimeters is considered severely deficient and a high risk for sleep disorder. Looking at the relationship between upper and lower teeth is important, as you can mask a transverse issue dentally by tipping upper or lower teeth. And if you can imagine, a normal disc is about 4 millimeters. If the disc becomes displaced or torn, you lose vertical height, and this negatively can affect the airway. So as you can see from these photos, I checked off every anatomic box we have in the prototypical airway patient. In 2021, I lost my bite. My teeth started to chip, and I was snoring again. I was using dilators and appliance. I did laser treatments, but it wasn't enough. I still only had mild sleep apnea, but I was now on high blood pressure meds. I felt tired all the time, and I was becoming increasingly concerned about my future health. I figured I needed to fix the anatomy. I was transverse deficient, bijaw deficient. I needed MMA, but starting with expansion first seemed like the next step. So what do we do now? As my favorite Peloton instructor, Dennis Morton, says, I make suggestions, you make decisions. I believe proper informed consent must revolve around educating patients about both their anatomic and their metabolic issues. Look at all the options we have at helping patients both surgically and non-surgically. The goal of both, enlarge the hard and soft tissue dimension, you'll improve flow. But how do we decide what's the best way to help our patients? The first goal will be to see how we can get our patients sleeping better. The second goal will be to manage their condition. And the third goal will be discussing ways to fix the problem. Fix the skeleton, teeth, soft tissue, so they can be without an appliance or CPAP and improve the quality of their life. But I've begun to ask questions. Is this enough? Are we truly fixing patients? Why are they relapsing if we've idealized the anatomy? So I now have a fourth step, which I've implemented, and that is helping patients improve their metabolic health. So let's discuss some of the anatomic ways we can help patients. Patient has to be able to breathe through their nose. That is critical. Opening the nose allows for improved breathing, and mouth tape is designed to keep the lips together. If you're a mouth breather, how does the air get around your soft palate and tongue? The tongue needs to be on the roof of the mouth, creating a proper seal. If tongue muscles create a downward pull as the patient enters deeper levels of sleep, the mouth is going to pop open. So combining mild functional therapy and using light scalpel CO2 laser, we can improve tongue function for this vital role in health. Both erbium, YAG, and CO2 lasers can warm and stimulate the tissue to lay down type 3 collagen. This creates more tone and the anatomy by shrinking the soft tissue, opening the airway. The mechanism of action is photothermal, thermomechanical, and new collagen fiber formation, all of which improve the thickness, elasticity, and firmness of the mucosal tissue. It's important to understand that this is not an ablative procedure. If you overheat the tissue, you can cause injury. You don't want that. But ablative procedures create tissue damage and wound response that results in a scar tissue formation, which over time has been shown to make sleep disorders worse. This is before and after of my mouth after my second night lace procedure. Notice you can see my pharyngeal arches and top of my uvula, but you can still see the scalloping and the downward pull on my tongue when I open. My VO2 max improved with my laser procedures, and I became healthier during the day as my body didn't have to work as hard to breathe. Lasers can also be used to treat nasal stenosis, strengthening the collagen. It helps prevent the collapse to improve nasal breathing. This is immediately after the procedure, and he was breathing in the same. So which patient is ideal for laser treatments? You start by evaluating the soft palate on the CBCT. Is the length greater than 35 millimeters? Is the width greater than 9? Remember, the impact of the bones directly impacts the soft tissue. Secondarily, you have to evaluate its relationship to the plane of occlusion. If the soft palate is at or just below this plane, laser treatments are not the first choice, since in these situations it can result in velopharyngeal insufficiency. Next, you look at the uvula, the color, the size. Can you even see it? It's normal on the left, and I don't even know what that, it's like a thumb on the right. You can reduce the size of the tongue volume by targeting the adipose tissue, which can increase in the tongue and reducing the lingual tonsil size. Non-surgical lasers are highly absorbed by water, which is a significant component of fat cells. So where do we treat and why? My laser's broken down into 3 sections. Let me start by showing you in real-time speed. I'm going to try to. There we go. Okay. The procedure. So this is the speed I move and the target areas. The difference between the Fotona and the light scalpel is time. Both are non-ablative and both are achieving the same outcome. The difference is ultimately speed. CO2, since its wavelength is higher, penetrates deeper and faster. Erbium's depth is more shallow and creates channels via smooth pulsing to get to the same depth. The protocol for each is the same. Patients rinse with hot water, which conditions the tissue and stimulates fibroblasts. I have them swish and swallow 3 times each for the target areas: floor of the mouth, back of the throat, and the tongue. Starting with the floor of the mouth to contract the muscles and lift the hyoid bone. This will pull the tongue away from the airway. And I also start with it to gain more visualization to the back of the throat. And since the tissue is thinner, it helps me gauge patient sensitivity. Next, we do the soft palate, pharyngeal tissue, and the uvula. I do not numb for this procedure. Patients should feel heat, but it should not hurt. I want feedback from the patient. If they feel pain, the tissue is getting too hot and is getting injured. The tissue should not turn white. If it does, too much heat is happening and it's being damaged. Finally, I do the lateral border and the back of the tongue to reduce volume in the adipose tissue. I have the patient hold their tongue out and each side for better visualization. It's critical to use high-speed suction to mitigate the odor and also the plume that's coming off the soft tissue. There's no downtime. Patients feel a sore throat that never comes. The key is drinking water and keeping the tissue hydrated. Patients start to feel more room almost immediately. And to date, I've never had any ulceration or post-operative discomfort. This patient's snore lab went from 110 to 40. We did a second treatment where they dropped to 25 on average, and then we finally did a mandibular advancement appliance to get us home. In my protocol, I increase the power as I move from the floor of the mouth to the soft palate to the tongue. And the total treatment time is about 10 minutes with no restrictions. The number of appointments varies and is based upon soft tissue anatomy. So regardless of the laser used, this is our goal.
Just completed a laser treatment for snoring with Dr. Cohen, my 3rd session. The treatment itself takes about half hour, 45 minutes. It helps to shrink some of the tissues on the inside of my mouth and improve my sleeping. My wife is very happy because she's not sleeping with a pillow over her head for the first time in like 10 plus years. And I'm sleeping through the night, not waking up like normally once, twice, or 3 times. And I'm feeling better. So, and right afterwards, it feels fine.
Both lasers can achieve the same outcome, different wavelengths, but same objective. But the business model was vastly different, and managing patient expectations in today's microwave society was a challenge. I was looking for a treatment with predictive outcomes that was more efficient and helping patients while lessening their financial burden. Night lays was 4 appointments, anywhere between $600 and $800 for appointment based on where you live. Each appointment was 45 minutes. Results are slower, and it opens up to frustration and medical fatigue, and patients still may need an appliance. The night S procedure takes 10 minutes, and I schedule a second appointment 3 to 4 weeks later, but I base it on snore lab results. If the numbers go down but above 10, I do another treatment. So I used to practice sleep medicine in a very linear fashion. Anatomy is the problem. Fix the anatomy, fix the patient. But I now understand there are many etiologic factors, and you can enter the paradigm at any point. It is our duty to inform patients they have options, both anatomic and metabolic. The combination of the two will have a better outcome. I wish I would have known about taking control of my metabolic health before I did MARPE. Would it have corrected my problem? I'll never know now. But I believe in my heart I had this procedure done so I could share this with all of you to learn. We need to show patients there are options. The challenge is most patients want the quick fix. We need to keep asking questions and demanding more from healthcare outside of medications or surgical procedures, which both have side effects and can have unwanted outcomes. I believe we can't just look at anatomy. Like cancer, heart disease, and cognitive diseases, sleep apnea is classified as an inflammatory disease, and it becomes a self-feeding loop. Sleep fragmentation or apnea leads to inflammation with a proliferation of cytokines and hence an immune response. And this in turn exacerbates disease. In the case of patients with sleep disorders, inflammation makes the airway worse. We have to break the cycle to help our patients. Fixing anatomy without making metabolic changes increases the risk of relapse and disease. Still, I'm asking more questions, like is too much oxygen bad? Could surgical expansion and surgery not be as good as we thought? I don't know, but I do know that the mitochondria will siphon off oxygen, and this leads to free radical formation and an inflammatory response. Medications have their side effects. CPAP increases the risk of cancer. My eyes have been open to more options. Many times I thought I figured out the answers to helping my patients, only to then learning that I didn't. And that's okay, that's medicine. But I'm open to new ideas and giving my patients choices. Every day I show up to learn more. This journey has been hard, but nothing worth doing ever is. Treating sleep disorders today, we now have more tools at our disposal, like lasers to improve soft tissue anatomy. Our job first should be to explain each patient their options and benefits to treatment. Educating patients helps them own their health so they can say yes to treatment. But anatomy is just part of the story. In future presentations, I hope to show you how providing metabolic options and combining them with our anatomic treatments will optimize health, reset the circadian rhythm, which is critical to health, and reducing chronic disease. Fixing anatomy without understanding your patient's metabolic issues has the potential to make our patients worse. Change is hard in the beginning, messy in the middle, but worth it in the end. I love being here tonight to share my story, and I hope I've shown you all the importance of living your why.
Well, you certainly have. Thank you so much. That was so informational. And I have never seen those procedures done before firsthand. So that was really eye-opening. I'm sure that we do have some questions in the chat, but really grateful for you to getting to the last why, because I think we're the why seekers, especially everyone on this call. That's why we're here. So I don't know if we'll ever get to the very last why, but there is a question in the chat. It is, what is your success rate with the non-ablative laser? In our clinic, we're getting poor results, but we haven't treated floor or mouth or tongue. Where did you learn to treat those areas?
So, where did I learn to treat those areas? That's a good question. So if you understand the anatomy of someone's airway, when you look in someone's mouth, you can see that their tongue oftentimes is very big. And you know that the tongue is filled with adipose tissue. So treating that to reduce volume is going to help. Treating the floor of the mouth, you're going to improve the muscle tension that's going to pull the hyoid bone. And when you do that, the tongue will go with it. So I started using a Fotona laser in 2018. And then, so I learned technique from there. And then I went to the Breathe Institute. I saw Dr. Zaghi's technique. And then I've pretty much just made a combination and developed my own that works pretty well. I think it's really critical, when we are looking at, and this is the reason why I showed my CBCT, the airway is a three-dimensional tube, and you need to treat it in all dimensions. If you just treat the soft palate, you're only treating one area that's affecting things. You have to incorporate all three. Case selection is critical when doing laser procedures. I think when I started really looking at what was going on and picking my patients better, and in my courses, I really dive deep into that. And then I'll tell you that, I'm really big into resetting the circadian rhythm and metabolic health. I failed MARPE. So I opened, my God, you saw how big I opened. When I did my sleep study after I did MARPE, my HI went from mild to severe. And everyone told me I needed more anatomy, more surgery. I was actually scheduled to have double jaw surgery on December 11th with Mike Gunson. But it just didn't seem right. Something seemed wrong. And that's when I learned about metabolic health and sugar, blue light, EMF, sunlight. And I now have no apnea. I'm on no medications. I don't use an appliance. I don't use breathe strips. I don't snore. And I believe that everything, whatever the disease, it starts with metabolic health. And we have the ability, Jenna was talking about when she did her intro about how her genetics, she won the lottery ticket with what she was born genetically. And I say that in jest. I firmly believe that we're born with the genetics that we are, but environment is what pulls the trigger. And we need to maximize and improve our environmental surroundings to prevent our genetics from coming through. And this is all based in circadian and quantum biology.
What type of metabolic guidance do you feel comfortable giving in a dental setting? Any specific course or research you share?
Yeah, so I actually do a concierge package with my patients where I help them. So when I told my physician what I did, he looked at me like I had 6 heads, because he could not understand how getting into the sun, blocking blue light, reducing EMF, and reducing my sugars was able to take me in 3 months from severe sleep apnea to no apnea. And I asked him, I'm like, well, what do you know about circadian biology? And he said, we had one course. I know more than them. And my course goes through exactly how you can help your patients and be an advocate for them, review information, and give them suggestions that can really make a change regardless of what their problem is, because all disease is based in inflammation. And if you can improve someone's inflammation, you can improve their overall health.
What laser wavelength is needed for the laser procedure that you demonstrated on the tongue and soft tissues?
You can use erbium or you can use CO2. The settings are going to be completely different for each one. Erbium has a wavelength of 2,900 around there, and CO2 lasers is 10,000. So the difference in the wavelengths has to do with how quickly and how deep the energy goes into the tissue. So a CO2 having a wavelength of 10,000, it's able to get to the target tissue area very quickly.
So a comment that's coming up, questions is struck hard as a chord, is that you said that CPAP can increase the risks of cancer. Can you please explain that?
Yep. So they did a study. I don't have it handy with me. It's actually in my presentation. That when there was the recall with CPAPs, they found one of the reasons why there was a recall was because of the foam. Well, what they also found was that of the people who had cancer, 10% of them, it was not related to the foam at all. So if you think about the concept behind that would be, there's something that's called a Warburg shift. And a Warburg shift is when someone is metabolically unstable, oxygen becomes toxic to the body. And when oxygen becomes toxic to the body, that's the cancer pathway. So I believe that is why I got worse from expansion, because my body couldn't handle all the excess oxygen that it was occurring. So that's ultimately the problem. And then, if you look at CPAP, what compliance is considered 4 hours a night, 3 times a week or 4 times a week, that's really not helping people. What happens the rest of the time?
Thank you.
Yep.
Did you lose weight during the 3 months of your apnea?
In my total, when I found my metabolic solutions and started actively changing my life, I lost a total of 40 pounds.
And do you think we should start with improving metabolic health? Is that where you begin?
I believe that if you want to ideal your care, yes. But that's why I was saying in my presentation that I used to be linear. Not everyone is ready to say, is not ready to do everything at a certain point. I started my journey with getting a constant glucose monitor, but then I learned very quickly as I got into the biology, into the physics, that fixing diet is way down the list of fixing metabolic health. You need to go earlier.
And then last question, so we can get to Dr. Schwibner, is can you explain why you cannot do soft palate laser if uvula is short, if they cannot snore with suction hold?
Because if you do the laser, you can cause velopharyngeal insufficiency where the soft palate does not close up against the back of the throat. And that's not a fun thing for patients. It's when whatever they eat can come out through their nose and change their speech. So if I have a patient that's right at the level of the back of the throat, I don't do laser treatments for them.
Well, thank you for sharing your story, and we're really inspired. We learned a lot from you, and we look forward to continue learning from you. And really appreciate you being here. So thanks again.
That's my
I'm
pleasure.
going to go ahead and introduce Dr. Jenna Schwibner while she gets her screen ready. It's my pleasure. Dr. Jenna has been practicing as a general dentist in Vero Beach, Florida since 2011. And in the last 5 years, she has transformed her practice from restorative dentistry to over 75% airway treatment, including comprehensive airway orthodontics for all ages, ranging from removable options to bracket and wire, tethered oral tissue treatment utilizing the light scalpel laser and mandibular advancement appliances. After graduating from the Dawson Academy's comprehensive dentistry curriculum and earning her fellowship with the AGD, she heard Dr. Ben Morales speak at a Dawson Academy alumni meeting in 2019, which altered her entire career. This was the catalyst for her speaking endeavors and involvement with AHS. She launched Foundation First Dentistry in 2022 as an educational platform for parents and patients and other medical providers on the importance of placing airway health at the forefront of any dental evaluation and treatment plan. We are thrilled to have our alumnus and pioneer, Dr. Jenna Schwibner. So welcome. You can just come off mute.
Yes, that's always important, right?
Yes.
So thank you guys so much for having me. I have so much that I can learn. I feel like I'm in a CE right now myself, learning from Andrew and Piya, and it's just so amazing to hear everything that you guys have done. So I want to go over my story right now. So I am gonna talk a little bit about myself and my journey. I talked about it at the intro here, but not the most flattering picture, but where we all started was I had the BRCA gene, and I had surgeries starting in 2016 for preventative mastectomy. And what I knew was I wasn't going to be able to breastfeed when having this surgery. But I decided that, being there for my children and not getting cancer was better than not being able to breastfeed. And I always knew that as a dentist, they were going to have some dental problems. I had no idea that those dental problems, that malocclusion, that lack of breastfeeding also could result in their full body health issues. But, I always knew I could fix the dentistry. So you can see in these pictures, my son, my first son, Ari, you can see his beautiful cheese smile on that left side, with that open bite in the front, which did eventually close down when he finally got rid of the pacifier, which, he had the pacifier until he was 2.5, 3 years old. He was pretty attached to it. And then you can see he transitioned to that sippy cup on the right side and, holding his sister when he was 3. So he always, had improper habits. And I'm amazed, but my 3 children, none of them had tongue restrictions or tongue ties. It was all environmental, pacifier, bottles, not breastfeeding. So at the end of the day, I'm taking these courses and learning these things, and it's a lot of mother guilt that goes into this. So I think as mothers, as parents, as dentists, we all, even if we could breastfeed, even if our child didn't have a tie, most of them, we had to get to work. Pacifiers, bottles, and I always knew sleep was important, not to the extent that I know it now, but I always knew that my kids needed to sleep. So I learned all about how to sleep train a baby, and I knew that my sleep was important. And to this day, my kids know they don't wake me up, they wake up dad, because mom does not do well without sleep. So I always knew that was important. But I wanted to do better for my children because I knew they were going to have malocclusion because of my immense mother guilt of not being able to breastfeed and having pacifiers in bottles. So this was 2019. It was funny enough, I pulled up these slides when I was looking for some pictures. I was trying to find pictures of me with my surgeries, and I really realized I didn't get in front of the camera much during that traumatic, years of my life there. But I did find all of these slides because despite surgery after surgery, and I all 3 of my kids were actually through IVF. So part of me is like, oh, the world maybe didn't want me to have children, but I fought through. And had IVF, had all these surgeries, and still was always committed to continuing education. So I was committed to being a complete general dentist. I wanted to be the best general dentist you could possibly be. And so I went to the Dawson Academy. I did their whole curriculum in record speed, as fast as we possibly can. I need to learn this so I can come back and be the best dentist for my patients. And so 2017, I got the award that you see up there that showed that I finished the concept of complete dentistry, the Complete Dentist Award. And I kind of laugh at that now because I was so not a complete dentist yet. And that was 2017. I knew nothing about Airway. But yet I got an award that said I was a complete dentist, and so did all the other doctors in the room. And then it was just a few years ago, I've gotten a little bit more aggressive in my presentation when I talk to people now, I guess. But I ran into a doctor in town that was saying, that he's a comprehensive concierge dentist. I asked him if he knew anything about the Airway, and he looked at me like I had 2 heads and said no. And I said, well, with all due respect, you can't call yourself a complete dentist if you don't know about the Airway. And you know what? I would have said the same thing to myself in 2017. And so luckily the Dawson Academy, we on the lower left side, all the dentists out there probably recognize the dots and the lines, and everything was about, let's get this perfect occlusion, this balanced occlusion, anterior guidance, all of that. And I was like, okay, great. I can do that. I'm a great dentist, but something was missing. Even patients that might have had that, there was something else going on. And so at the Dawson Academy, they said, we have to look about the airway. And these are slides from the Dawson Academy Airway Conference in 2019, the beginning of 2019. And I thought that was so interesting because it talks about identical twins with different habits and how their jaws developed, talking about the habits. The slide that says it's all about airway, all of these things I didn't remember learning, but I'm like, wow, they were in there in my head. The postural theory of malocclusion, children's deficient growth and development, right? So here I am, pregnant with my third child that I did IVF for, that I knew I wasn't going to be able to breastfeed, and the mother guilt is building. Oh, and also I believe Dr. Boyd was actually there talking about how when you're stressed out when you're pregnant, like you can really harm your child. And I'm like, oh my God, I've had surgery after surgery, and not to mention being a dentist and being a mom, and the mother guilt was just piling on in this course. And I was like, okay, well, I guess at the very least I should learn how to do orthodontics for my own children because they're going to need it. And so what can we do from there? And then, they talked about the evolution of orthodontics, that we can no longer ignore these issues. We should know these things, these barriers of growth, and we have to make change. So a major barrier to growth is the unwillingness to leave what has become familiar and comfortable, but has continued on past its time. And after that conference, I heard Dr. Moralia speak at the alumni event, and it was just like, oh my God, I was getting bombarded with airway, airway, airway. You're not a complete dentist without learning airway. And so I learned everything, thought that I was ready to be a complete dentist, and I completely changed. And it's for these guys. So this is in the last year. I have 3 of them. The one on the right is the one that had that anterior open bite, no space between the teeth. Once that anterior open bite closed, you had a crossbite on one side. Number 8 and 9 was growing in a crossbite by the time they first erupted. And he has not had braces. He has not had aligners. He just has done expansion and guides. And we're still just waiting on number 11, which decides to take its own time, but it has plenty of room to come in. And if he didn't have congenitally missing number 20, which once again, my fault, mother guilt, I grew him wrong, he wouldn't need a thing. So we're going to have to do a little bit of alignment to make sure we hold space for number 20 till he can get an implant. But besides that, a pretty amazing smile with just expansion. And my middle daughter, she's severely crowded. And so we just finished her first set of expanders. She'll get another set of expanders. And then that little guy to the left, he's wearing a guide, and he'll move into expanders. So at the end of the day, I feel confident that I can treat my own children. And none of them needed releases, so I didn't know if I should talk about them in this presentation, but they are my why. They are, as a mom, mother guilt is the most powerful motivator to make yourself better. So I powered on. And then once you learn how to do this, you realize that, laser technology is something, I've always been high-tech dentistry, even before I got into airway. My practice's tagline when I was a general dental practice was high-tech dentistry with a soft touch. So my previous partners were incredible, and they had every technology out there. They had one of the first lasers. They had a hard tissue, a soft tissue. They did everything. So that was also ingrained in my mind of, okay, technology is how we treat our patients better. And patients are always wanting minimally invasive treatment, better outcomes, better access to care. How can we be faster and better and have less pain? So I'm always getting the best thing you can get. And so for me, I was doing tongue ties really since I graduated dental school. I don't know why, I did them always, but I didn't like them because I was using a diode, and then I was using, I even have the Photona, but nothing was easy. I dreaded it, and the patient dreaded it. So I wasn't advertising them. I wasn't doing them until I got the CO2 light scalpel laser, which is just super precise. It's used in dentistry and surgical. You can literally remove like a cell at a time. I mean, it's so accurate and clear, and there's minimal bleeding. Usually I do anesthetic. So I make them bleed from the injection, and then I have to cauterize that with my laser as I'm cutting away. But as I'm cutting away, I see the fascia melting away, and I can dissect it out so that it's super fast and simple on an infant, which I was terrified to release an infant with any other laser. There was no way I'm taking a hot diode to an infant, or a laser that needs water spraying everywhere on an infant. No way. This is the only laser that I would touch an infant with. And as soon as I started doing that, you know, the rewarding feeling of helping a mother feed, I felt like, oh my God, I can give these moms something that I never was able to do. And to me, I wanted to breastfeed so badly. I actually didn't have my mastectomy till after my first one was 2, because I was hoping to breastfeed. I was planning on breastfeeding all my kids, finishing that, and then having my surgeries. But I had a breast reduction when I was 16, and the scars made it so I couldn't. So I was in tears. And so to be able to give that gift to mothers is just amazing. And so I use it on all ages. I have infants all the way up to adults. So I think my oldest patient I did a release on probably was like 75, that we were in combination of some expansion treatment. So I don't age discriminate. And I just wanted to show you guys this, like why we use this laser, because it targets the tissue. There's way less trauma than any other laser I've used. And this is a kiddo. We don't need the sound on this one, so I'm going to turn it off because it's just me making like funny sounds to him to make him excited for what he just did. So we just finished the frenectomy on him. Okay, so he's numb, super cute. You can see it. He's 6 years old. And he's numb, so it's not like a perfect lift. But I'm like, okay, lift your tongue. Let me see how that goes. And he was just no big deal. No tears, no crying, no soreness. He did great. I would suture that now. I wasn't suturing all the kids at that time. I did now. And then this is an infant. So obviously when we don't have post-op pain and swelling at the same level, when we don't have less bleeding, then we're going to be more likely to do it on infants. So this is a couple minutes, but I want you guys to hear what the impact this made for this family. And they drove 2 hours to see me just to get their baby feeding, which just shows the need for other doctors to be doing that. So tell me, it's not going to play. Let's see. You guys can't hear it on your end, I guess, huh? Let's see. Let me see if
You may have to enable the sound when you first share your screen to hear it.
All right, we might not be able to do it. I don't necessarily know how to do that, but let's see.
If you wanted to stop share, enable it, and then go back to the slide, you could, or you want to come back to it.
Mm-hmm. Let's see if that works. I should have tested the video before. No.
Why don't we go forward, and then after you, then you go back if you want to enable the share sound.
Okay, I'll see if we can. So I have a couple videos, fortunately, but
all right, Jenna, why don't you stop sharing then and just go back to the slide, and just there's a little box that you'll see to click to.
Okay.
So press share screen and then enable sound. Should come up when you share your screen. It's like a little checkbox.
Share sound.
Yeah.
Okay.
And then we'll go back.
Okay. Let's see if that works. I'm gonna get this right one of these days. All right. So have little Charlie here that had a still not really playing on my side last week.
No, we hear it. We hear it.
Oh, you do? And so tell us how the experience was.
It's been fantastic. So he's latching way better, way less gas, way less fussiness. Was unable to sleep on his back prior, lots of reflux, gagging, choking, coughing. He can sleep on his back now. He's definitely way more comfortable. We've seen roughly 4 or 5 other doctors that had no idea he was lip and tongue tied. And then we actually went to our chiropractor, pointed us in this direction, and it's definitely been the one thing that's actually solved the problem rather than just treat it. And yeah, he's just a way happier baby, and we're just looking forward to him being happier and healthier. So.
And he would spit up every feed, and now I would say it's almost non-existent. So.
And one thing you guys said that we wanted to do this video was because
there's a lot of misinformation out there and a lot of parents that are suffering, but maybe they don't have to suffer as much. And so just letting parents know that.
Right, and he actually had an issue too where he did aspirate on his vomit prior to this. So we were wondering if, maybe tongue ties, if addressed earlier on after birth, could possibly help, with even some SIDS issues and possible outcomes that maybe would save some parents from going through some like traumatic experiences like we had to go through for
right,
sure.
Because we got to him a little bit after and he already wasn't breastfeeding anymore and is now on the bottle. But if we got to him sooner, maybe we would have been able to make that a little bit better for you. You guys
More
suffered for how many months?
Oh gosh, what, like 2.5 months?
Yeah,
2.5.
2.5 months.
Yeah,
but we're glad you found us now, and
for sure. Yeah, I recommend anyone to come for sure. It's been a lifesaver for sure for us with sleep and him especially. So he's just happier and he can sleep now and relax, and it's been great. So
happy baby, happy parents.
Yeah,
Thanks, guys.
right.
You guys can hear that because I can't hear it on my end, but
No,
I've
we can
heard
hear
it
it.
before.
Yep.
All right, perfect. So as you can see, I mean, just super great result for an infant, and I was terrified to treat infants. I'm not a pediatric dentist. I wanted to be at one point, but that's a scary thing to do, take someone's little baby. But at the same time, it's worse not to do anything. So you have to help these families, and that just warmed my heart to see that. And then we also do adults. So as a general dentist, we have the youngest ones, and then we have this adult patient. And this adult patient, she really needs some other work, some expansion, some, different things as well. But this was just the tongue tie, which was interesting because most of my patients, they do the tongue tie at the end. They've done expansion, they've done some type of dentistry. And so when they get the tongue tie, it's hard to know exactly the benefit of just the tie versus everything else and what made the biggest impact on these patients. But this patient just had the tie and that was it. And her results were incredible. So I wanted you guys to hear from her as well, what a tongue tie release with the CO2 laser did for her. And this was at the myofunctional therapist office. This is Myo Air, which I'm so lucky. My life really got changed when Myo Air's partner, Joanne, moved to Vero Beach or Melbourne, Florida. I was just so lucky. I was already training with AHS through Dr. Moralia, and Myo Air, was also part of the AHS curriculum and training. And then Joanne moved down to Melbourne. And for me, a tongue tie release is only as good as the therapist you're working with. And it's really important to have a good myofunctional therapist that can work with your patients before and after. And my results and my patient's experience just increased tenfold, 100-fold once I started working with Joanne, because they had the support and they had the healing. And, I could do a beautiful surgical release and they can go right back to where it started if they don't heal properly. And so I encourage all of you, don't just do a release. If you have a laser, don't just, they're here, they have a tightness. Oh, I see it, it's staring at me. Like, I can just do it right now. And you don't want the patient to spend a lot of money. You don't want them to do a lot of hassle. But I tell the patient, I'd rather not do it at all than do it without therapy. You're not going to get the benefits. And I might make you worse because now I'm giving you scar tissue. And you know what? If you can't do it 100%, we're just not going to do it. So patients respect that. And I really don't get people saying no. They do it. They figure out a way to do it. But please, please, please get with a myofunctional therapist. They will be your best friend and your biggest practice builder, your biggest practice grower. The amount of patients that they've sent to me and the relationships we've made have been incredible. So listen to which.
Can you tell us your name and why you came to Myo Air?
Hi, my name's Stephanie Cooksey, and I came to Myo Air to help with chronic tension and muscle tightness, and also sleep apnea, supposed sleep apnea diagnosis, and open mouth breathing at night.
And you got your tongue tie released?
I did get my tongue tie released about 4 weeks ago now.
And how are you feeling since you had that done?
I'm feeling fabulous. Honestly, I feel like a new woman almost. All of the tightness in my shoulders, being up all the time. They now are down further. I can turn my head 90 degrees in both directions, which I've never been able to do for my entire life. The best analogy I can give you is that I was hogtied for a lot of years, and now I feel as if it's been released.
That's amazing. So you would definitely recommend others do the same if they're experiencing the same
I would
symptoms?
recommend, yes. And don't believe anyone who, everybody that says, oh, you don't have a tongue tie. Come to a professional and really be evaluated and make a decision for yourself. It's the best thing I've done.
And would you recommend MyAware to your friends and family?
I would, absolutely.
Awesome. Thank you so much, Stephanie.
I appreciate it. Thank you.
Thank you.
So one of the things I'm really excited about this patient is she's an educator at the school that my kids go to, at the private school they go to. So the more we can help these adults, I really want to help more children because they're the ones we can change their life trajectory so much. So by helping these adults, then they know and they educate and they go back to the schools and they say, hey, we can do better for these children. I'm breaking the whole, everything in my town. No one's doing this. People are flying in from out of state, driving in from all over Florida, been flying out of state. I'm a general dentist doing orthodontics and charging more, I believe, than the orthodontist for the most part, because I'm doing more, right? We're doing expansion plus other things. And patients are coming in and doing this because we're helping solve issues that no one else knows how to solve and actually get to that why. Get to that why that the mom has, knowing that their child has problems. So helping adults helps children. So these are some before and afters, just because this is a laser discussion. I wanted to show you guys just how beautiful the laser can be and some of the results the lasers can have. You can see that most of the patients, they have some aligners on their mouth and the kids have braces. So for me, the tongue tie release is the final step for the most part after we develop their dentition. So once we develop that palate, we develop the home for the tongue. I always emphasize from visit 1 when I do my consults that we need to release that restriction that didn't develop the palate properly, right? So our tongue is responsible for going to the roof of the mouth, for every time we swallow, for developing the shape of that palate. So we need to address the why. We need to address why that palate did not form properly to begin with, and it is the tongue. So if they have a restriction, we need to release it. But if they don't have a restriction, they still need myofunctional therapy, because that myofunctional therapy needs to train that tongue. Because if that tongue wasn't going to the roof of the mouth, there's either a restriction or a chronic nasal breathing and a habit. So we need to break that habit. They need the myo. And if they have a restriction, we have got to release that restriction, or else everything that we do is going to be prone to relapse. On the younger kids, we want to do it so that they continue to grow, because even at, when their orthodontics is done, maybe at 12 or 13 or 14, they're still growing. And so what do I see as a general dentist? And I feel like what really sets us apart as general dentists doing this is that we see the patients that were done with ortho, and then a couple months, a couple years later, they have relapse. And the orthodontist doesn't always know that or see that. They don't see the anterior open bite opening up because the patient usually doesn't go back. They don't see the TMJ breakdown, the abfractions, the recession, all of the issues that these patients have at a young age, because those muscles are pulling everything back, or that anterior tongue position, that anterior tongue thrust, all of that muscle dysfunction is going to create an unstable environment for that orthodontics. So it is so important. Get the musculature working the right way, get any restrictions released, and work with a provider to do that. For me, I do not have anybody in the area that was doing it. So my practice has warped and continued to become me doing whatever I need to do to provide access of care to my area, because there was not a proper release provider for adults or children or babies. So I'm doing it. There was not a proper orthodontics focused on airway in my community. So I did it. That's the benefit of a general dentist doing this, is you can do whatever your community needs. If I had a pediatric dentist down the street that was doing airway orthodontics, I would not do children. I would refer them. If I had a doctor that was doing proper tongue tie releases at any age, I would refer them, and I would be very happy doing my crown and bridge and going along my way. But at the end of the day, we have to help these patients, and no one was. So obviously these tongue ties, I think pretty nice results. The ones on the top are, healed after healing for I think they were each for like a couple weeks to a month. And then the bottom is right after the procedure. So you can see without sutures on the left, the middle is sutures, before suturing and after suturing on that patient. I believe that one on the right, we just did on Tuesday. That was just a couple days ago. So Tuesday's tongue tie day at my office because Friday's myo day at my myofunctional's office. So I do all the tongue ties on Tuesday, and then they see my myofunctional therapist on Friday. So it's just tongue tie after tongue tie after tongue tie on Tuesdays. Try to say that without getting your tongue tied. And then obviously the pediatric. So the light scalpel does a beautiful job, right, of just doing this right after surgery, nice and clean. On the right, that is, now suturing. That's the child that the video was on. So we see the top to the bottom, how nice and clean in that lift that child had. So I would have never have had the confidence to do this at this level if it wasn't for this laser. So definitely it's the doctor doing it, but it's the tool. You need to have the right tool to feel confident, to feel like what you're doing for your patients is good. So I already talked about this, so we'll kind of zoom through this. You need to get behind the why these arches are so narrow, and it's why are they having airway dysfunction? And it's typically that muscle dysfunction, that improper muscle placement. So we need to address that muscle. We need to do the myo. We need to do the releases. And orthodontic treatment is the side effect. Needing orthodontic treatment is the side effect of muscular dysfunction. So we need to address the why, not just the side effect, if we're going to get long-term results. So we must release that tongue into the space. And if they don't have a restriction, you need to at least get them to myo so that myofunctional therapist can work on the strengthening in the position so that tongue can be our forever retainer at the roof of our mouth. Because as we know, no one's going to lose their tongue, but they're going to lose their retainer. So if we can get that tongue working for us, they're going to be, much, much more likely to have long-term success. So when you see that patient that has crowded teeth like this, you have got to say, well, why, right? So we did expansion on this kid. He's actually still in process. He had 2 sets of expanders, very, very narrow, very, very symptomatic, extremely tight tongues and lip. And so anytime we do expansion, we need to do the release. So this is him, he has the expanders, and on the left is before the expanders are out, and he's in his next set, his aligners, his clear aligners on the right. So you can see that patient that we have to restrict that tethered tie in order to hold the stability of this orthodontics that we're doing. And so a quick little, one more patient and then we'll be done. So this is 8-year-old patient, 31 millimeters. So we know that's really deficient. Anything, at 8 years old, we want a minimum of 35, closer to 40 if we want to have room for all the teeth. And we can see how triangular and narrow he is in the front. And honestly, the main reason why he came to me to get treatment was because he had trauma to not number 9, but he had trauma to the primary front tooth, and he lost it when he was 3. And number 9 just never came in. So you can see it's just not coming in, and number 8 is fully in. So dad's like, hey, Jenna, we got to do something because this tooth isn't coming in. And I said, well, let's grab a CT. He has a tongue tie, he has all these things, but let's grab a CT. And that tooth is horizontal. So I messaged all of the doctors that I know through AHS, Dr. Bolding, the oral surgeon, and Dr. Boyd and Dr. Morelli. And I said, what are the odds of this tooth actually coming in? And we all kind of said, there's a good chance he's going to need surgery to get access to that tooth. It is so ectopic. It is so horizontal. But what we all agreed on was this kid needed expansion anyway. I mean, look at that chin. Look at how narrow he was. He needed expansion. So we said, okay, let's do the expansion. And if that tooth doesn't erupt properly, then we'll have to get him to the surgeon to try to help bracket that tooth and pull it down into the space that we correct. So Dad's like, okay, we have to do the expansion anyway. And he needed the tongue tie release also. So I put him on here because the tongue tie is not the reason why he lost that front tooth at 3 years old. That was being a 3-year-old boy. But how narrow he was at 31 millimeters across, that did not help the situation of these teeth coming in. And that was part of the why of that deficient jaw and that narrow arch is that tongue tie. So that's his tongue tie. And this was, after we released it. And you can see here the before and after of the expansion. So that tooth came in and it came in once we expanded, it just started dropping in. And then I did have to grab it. I put some phase 1 brackets on him to pull it into place to help. But he didn't need surgery. He didn't need anything major. The tooth just came in. And then, we released the tongue into that beautiful home that we built for him. And he'll still need some, some guidance and some continued treatment. But this was a huge service for this child. But at the end, I wasn't done. Even though my orthodontics looked pretty good after phase 1, we weren't done until we released that tongue and helped him continue to grow without my hands in his mouth. He needs to continue to grow naturally on his own with his tongue, with his proper tongue position, with his myofunctional therapy, and all of those things need to come together, or else whatever you do is just going to relapse or at least be much, much less successful. So that's what I got for today, guys.
Wow. Well, thank you so much for sharing. And it was nice to see the whole case from start to finish. It was a great way to finish out and see what you can do when you put the tools and combine everything really for the benefit of the patient. And I loved your story with being a complete dentistry to how that evolved for you. And I hope that other people be curious in airway dentistry and how they can also help their patients. So wonderful presentation. We do have a couple of questions in the chat. Oh, how old was the woman patient that you showed, and what are some nuggets to encourage older clients to accept treatment and not say, I'm too old now, or I've lived this way so long, why change now? Good question.
Yeah, so she's in her 50s, I believe, 40s, 50s. If she might be listening, I don't want to get mad at me. I'd have to look. But 40s, late 40s, probably early 50s. So I have patients that are 75 that do this all the time. So she's young for my patients. I come from a retirement community where my practice was mainly 65 and over. So for me to start seeing these kids and these babies and everything, it's a complete shift for my practice. I love it. My partner was like, I'm never going to treat a child. So she's like, these screaming children in my lobby. And the children that are screaming are not the ones I'm treating. They're the siblings that all came along because they drove 4 hours to see me and the mom doesn't have a babysitter, so brought them all with them. That gets a little crazy. But anyway, the older patients, I have patients in their 70s all of the time that we treat for this, because we're talking to them about, well, why do we need to treat this? They don't want a CPAP. They want to breathe better. They want to function better. They don't want neck pain. They don't want body pain. So a tongue tie or a lip tie that an adult patient does not see is causing them issues, of course they're not going to accept it. They're not going to do it. If that tongue tie or lip tie is causing them something that's bothering them, they will 100% fix it. So it's getting to know your patient and talking to them. Do they have a lisp their entire life that they've ignored, or they don't realize they have? As I'm stuttering here, I mean, I have patients, adult patients all the time. They're lisping and they're like, I didn't realize I had a lisp, but I pointed out to them. And then they ask their husband's like, yeah, you do. That's just how it is. And they're like, oh my God, get rid of this, So, okay, my own tongue tie. We'll get rid of that lisp. You have a patient that's snoring. You have a patient that has airway issues. Okay, part of your comprehensive airway plan is tongue tie release and myo. And if they're going to invest in the ortho and the expansion and they want to really try to get off their CPAP and we're going to make an oral appliance, I tell them, I make a mandibular advancement appliance. There's only so much you can do. We need to cut that AHI number in half as many times as possible. Myofunctional therapy and tongue tie release combined can decrease your apnea by 50%. When they hear that, sign me up. And guess what? And sometimes if they're on the fence, I'm like, might not need it. You're borderline. But the myofunctional therapy will help. So we get them in with the myofunctional therapist, and that Joanne, she's going to get them to do the tongue tie. So you're not going to do a release on an adult without a myofunctional therapist. So get really, really good at getting them to the proper myofunctional therapist. And the thing is, many therapists will work virtually. So find one that you love, that you connect with, and figure out the verbiage to get them in the door with them. And they will convince them to get the release. I guarantee it. They'll educate them, and they'll make them realize the value, because when they do their full functional evaluation, they're going to see you have neck pain, you have neck strain, you have compensation, you can't turn your head this way, you can't do this. They're going to go through all of that, and the patient's going to go, oh my God, I didn't think this tongue tie was bothering me, but it is. I want this tongue tie released now, and they will come to you. So no patient is ever too old to get properly treated. And so we do not age discriminate. I tell every single patient, no matter what age, the benefits of it. And, on my Tuesdays, I'll do a baby and I'll do a 60-year-old like every single Tuesday.
At what age would expansion be recommended first and then release versus a child young enough for release and then possible ortho is needed later?
Yeah, so like Piya was saying, it does vary case by case, but if they are, let me see the best answer for this, because I do expansion as young as 3 years old. I do have some expanders and some 3-year-olds. We do myofunctional guides when they're younger. I would say typically I'm not going to put an expander in a child under the age of 6 unless they have severe misshapen palate, like very, very triangular. Yeah.
Do you mind if I chime in?
No, go.
I expand as young as 12 months old. So, but if you look at the growth curve, and I can share the name of the curve is blanking on me, but if you look at the growth curve of the maxilla, it kind of peaks at age 4. So for me, it depends on how severely restricted they are. And if they're under 4 and we're just, there's not a whole host of sleep issues, and they're a couple millimeters short and there's a tongue tie, I'll say, let's do tongue tie and work on the breathing and the myo. But if they're severely short and parents are reporting they're already hearing apneic episodes, then even if they're under 4, I'm putting in an expander, and I'll do it on a knee-to-knee kid. As long as I can get a scan, I'll put in an expander. So it's case by case, but
yeah,
the growth curve of the maxilla is really important to know that like 70-ish% growth by age 4 is done. So if we're at a 21 and we need to be at a 32, we're not going to get there just by releasing a tongue.
Yes, exactly. So I'm looking at that transpalatal measurement as well. So if we're the same type of way, if we're more than a couple millimeters deficient, so like 29 and less, then I'm definitely going to be more likely to say, and their symptoms, so if they're highly symptomatic and they're very, very narrow, it's like, let's just get them, let's make them bigger, let's do this. But if their anatomy looks pretty good on their maxilla, right? They have pretty good maxilla, but they have, the underdeveloped lower jaw, or their anatomy maybe even looks okay, upper and lower, but they're having symptoms and they have the tongue tie, you do the tongue tie first. But on these older children, 100% when they're, 6 and older, I'm doing the expansion first. So that release is going to be more successful if we have a home for that tongue to house. So we want that patient. I don't want them to go through myo and get that, all that training before, and then we put an expander in that occupies the palate, and now they kind of get bad habits again. Like, I want them to get the most bang for their buck if they're of that age that we can do an expander, of 8 and older, for sure. I'm putting the expanders in 1-2 months prior to removing the expander. We're getting the myofunctional therapy to work with them. Then we're doing the release right after we remove the expanders, getting them into some functional guides at that point, if they're, in that lower mixed dentition. And that works really, really well for me. And I don't like taking off an expander until I have that myofunctional report and I know that they've seen them, they have appointments. I'll kind of I'll be like, I'm not taking this off, until you go to the myofunctional therapist. And if they decide not to, they say, I can't afford it, or I don't want to do it, or they don't see the value. That doesn't happen a lot now as I get better at telling them ahead of time about it. But that once in a while, you get that, Mom, I'll either do the release for free, and I'll convince my myofunctional therapist to give them a break, which is usually what we do because we just won't let a patient suffer. we, they realize the importance of it because I'm like, I can't guarantee that this isn't going to completely relapse. They make it sound really, this is going to completely relapse if you don't do it. They understand that. And then, they go and they get the therapy. So I know before I remove those expanders, they're working with the myofunctional therapist.
Thank you so much. I know we're coming out of time. I just wanted to welcome Peter Vietrich. He's CEO of Light Scalpel, and we're so excited about our collaboration. And I did want to mention that the panelists today are part of the Light Scalpel faculty, and all their presentations are based on their work and their preferences. So I just wanted to make sure we clarify that. And Peter, I don't know if you wanted to speak about anything about the laser aspect as from your professional point of view.
Yeah, so can you see me?
Nope,
can you hear me?
But we can hear you.
Yeah, what do I do?
I'm not sure on the webinar part. Is there a way? Let me see if I can ask for you to. Well, we can hear you, so let's go with that until we try to figure out how to bring you on camera. Oh, ask to start video. Okay, try that one.
Now is.
I think it's working. Yes.
Is good. Yes.
Thank you.
Hell of a day today, but I'm here. Yeah. So anything and everything about the physics, fire away. There was the question from the audience, the neurological erbium laser. If anything that we need to.
Let's see. There was. I think it was answered by Dr. Cohen. In the chat. So that was good. I don't know if there are any other questions about the physics of lasers. If you want to ask that, you can put it in the chat. But
the Andy's question was way better than what I would respond with. So.
Okay. So I just wanted to give you the opportunity, but I really just wanted to just really say how thrilled we are to collaborate. I'm just going to go ahead and share my screen on this collaboration and why we decided to do it. Let me just get this here. And I present here. Okay. So I just wanted to talk about this because it was a natural collaboration. It seems like we have mutual interests and really the same drive to educate on airway as well as laser education. So we just wanted to say how excited we are, and we have invited these three panelists to join the AHS faculty. So that's another disclosure that we wanted to discuss, but we're doing so because of how their why, and then how they're doing it, and then how you can implement this into your practice. So Airway Health Solutions is our title of our company because we want to provide solutions, and we really think that this is a great fit. So I don't know, Peter, if you wanted to add anything to that, but we're thrilled of the collaboration, and we're thrilled of these presenters and having them join our AHS faculty in the near future. Peter, did you want to mention anything? I'll go right ahead into our flash sales and our raffle.
I'm super happy with this panel discussing how lasers can contribute as an instrument. It's not the one and done, and not the one and only solution. So this is I look at that as only if we can help, great. And the magic wand without the wizard makes no sense. And this is where the Dr. Cohen, Dr. Gandhi, Dr. Schwibner come in to really make it all work for the best of the patients. And any questions from the audience as far as how does this work, how does this does not work, I'll be happy to address, but really need to have those questions first.
Sure. Sure. So let's put that in the chat, and maybe we can do that as a separate webinar, so we can focus on the physics of lasers. But I'm happy to do that. But I just want to move on just to make sure that we get our raffle in, because I know it's late for some people on the East Coast if you're early birds like me. But there, let me just see. You can also answer in the chat, Peter, just because we're on short of time here. But is there an email that you can put in if people have any questions for you? Maybe you could put that in the chat as well, so they can email the questions. That would be really helpful. And let me just go some announcements. We are having a flash sale. This is actually only for those who are on the call today, and we mean that. We really want to kind of give you a really nice perk if you're on the fence about incorporating airway dentistry into your practice. From our end, for the courses that we currently have, I just wanted to offer something as a token of our appreciation. This is a flash sale to May 10th. You need to be present. We do check the attendance, so this is not for everybody, just our live listeners. So please think about taking advantage of $1,000 off our adult and pediatric mini residency. We're giving 50% off our pediatric airway health fundamentals course, so that's a nice option for you. And then Air 20 is 20% of all of our courses, including our Mayo. Okay, so please go to our website and see if there's anything, if you're on the fence about taking any courses, if you're kind of, wanting to learn, this is the time. We need more dentists like the doctors who presented today. I mean, we really need to fill the country with airway dentists so everyone can be treated. I'm not going to go into the details of the courses tonight, just to be mindful of everybody's time, but please visit our website, or if you're curious, you can set up a call with me to go over all of our courses in more detail, and I'm happy to do that for you. Okay, I do want to talk about Airway Palooza, because we're also doing the flash sale with $500 off. So that's going to be the highest ticket off at this time, because our early bird has passed. So if you're on the fence, or you're wanting to wait and need a sign to join us at Airway Palooza, this is your sign. And we are thrilled to have these speakers present this year. If you haven't been, it's a wonderful 2 days of fellowship and learning, and actually just a lot of fun. Everything's included. Top-notch, first class, and it's on the beach this year. We do have a free conversation series next week, really for the hygienists, and we want to talk about the valuable role they have in screening for airway health. So anyone who's not a hygienist on today, maybe you want to send this to your hygienist that your colleagues or your dentists as well. So that's what we're going to do here. And now we're going to do the raffle. So I'm going to go ahead and let Jay share the screen, so see who gets that free fundamentals course, and then we can close out with any extra questions. But let's go ahead and see who's the lucky winner. Okay, Angela Goldwait. Wow, you're very vocal tonight. So we have a winner. So that's an $800 value. We're thrilled. We will contact you and thank you for your support. And I'll just want to stop sharing the screen now so we can just close out. We do have a couple of minutes. I really thank you from the bottom of my heart, Dr. Cohen, Dr. Gandhi, Dr. Schwibner, really for sharing your personal story. You really shared a lot of details and being vulnerable, and we all learned from that, and we kind of get the reason behind your why. And as Peter said, these are all tools in your toolbox that you've just used because that's what you enjoy and the results that you're getting. So thank you for sharing your protocols, your whys, and we're looking forward to learning more from you in the future. Peter, thank you for having this collaboration, and we're really excited for the future to move the needle forward and really just to make this mainstream and part of complete dentistry from the get-go. Is anyone want to have a closing statement? I don't want to put anyone on the spot, but if there is something that you really wanted to try to say that we didn't have a chance to, panelists, please be free to come off mute and say what you would like to close out.
I'll say something.
Please, thank you.
I think, as I'm looking at a lot of the questions that are coming through, what our goal, the three of us tonight, was to show that there are a lot of ways to help our patients, and there's a lot of tools that we can use to help our patients. I don't think any of us is going to say that one thing is going to fix a patient. You're not going to be able to do a tongue tie release by itself. You're not going to be able to do a recontour of the soft palate by itself and help our patients. These are multifactorial problems. It's why CPAP compliance is poor. It's why mandibular advancement appliances, have a time frame where they stop helping people. Some people, it works really well with. And I think what we're trying to do and what we're passionate about based upon our experiences is just showing people that there are options out there. There are tools that we can do that are both beneficial financially for our practices, but also benefit patients' well-being. And that's why we're all here tonight, is we want patients to be healthier. And, Light Scalpel is a tool that helps me provide that for my patients. I use other tools as well. And I would never stand here and say that one tool is going to fix someone. That's why I showed so many options. So I think it's important to state that we're all just passionate, each one of us, and Airway Health Solutions and Peter. We just want people to be healthier and give them ways to do that.
And along those lines, I would say being able to identify what the problems are from a comprehensive standpoint is the first step. Like, not getting hung up on what's the treatment. It's what are the problems that we're dealing with, up from a bigger picture, from a multidisciplinary picture, because otherwise it's very easy to think it's a one size fits all, or kind of get stuck on what do I do to treat it? Well, first it's about the identification and education, and then moving on to what the treatment looks like.
And I think piggybacking on that, the most important thing you guys can do is, now that you know, is say you don't know, or say that, debunk the myths out there, because there's just so many people out there. I mean, we are fighting constantly of a tongue tie is not needed, a lip tie, tongue tie release isn't needed, lip tie release isn't needed. That doesn't matter. You shouldn't do orthodontics on a young child. And, there's so many myths. We could go on and on and on of wrong things said. Mouth breathing isn't a bad thing. Everyone mouth breathes. It's not harmful. Those things are being said every single day in the community. So if you at least know enough to say, you know what, like, that's not true. I don't know how to fix it yet. I'm still learning, but I know that's not true. You could help a mother. You could help a child. You could help an adult by, at the very least, you can get the adult. I know the CPAP causes cancer, Andy. I'm gonna ignore that for a second, because if you can't do anything else, I did start just by referring my older patients to the sleep physician in town and getting them at least screened and on a CPAP. You can put all these patients on life support. And if they say no and they aren't compliant, yes, that's a big issue. But there are a lot of doctors making mandibular advancement appliances, and there are a lot doing CPAPs. So for your adult patients, let's put those adult patients on life support while we're figuring out where to get them to, and they will travel. The adults will travel. They'll fly to see me. They'll fly to see Andy. They have the means to do that. Usually, especially the retired patients, like, they will go and get help. So at least with them, let them know the options out there. And it's very easy to get them to a sleep physician. They're virtual or in person everywhere. And it's very easy to get them with a doctor that does mandibular advancement appliances. So many dentists will make those. So you can help those adults just by doing that. And they will fly for the other doctors. For the kids, the most important thing you can do is start spreading facts and start telling people that there's wrong information out there, and these parents are spinning their wheels going to getting the wrong thing because they don't have the diagnosis. Just letting the parents know there's options, and there's some simple things we can do to help them. Just like tooth pillow alone is huge, because if you're in an area that doesn't have a doctor that can do this, you can get them to tooth pillow. Tooth pillow can do some virtual guides, at least get the habits, get them introduced to some myo, and then they can start finding providers. The mothers will Google, they will search, they will fly and see me and see Piya. They'll find us when those kids are really, really sick. So the best thing you can do is just give really good information and say, I'm not really sure, but I'm going to take some records and I'm going to talk to Dr. Jenna. I'm going to talk to Dr. Ben. I'm going to talk to Piya. I'm going to email Lauren. Lauren will respond and she will help you find a doctor that can help. And we will. I am constantly responding and talking to other doctors. And we are trying to build mentorship programs to support you guys so that we can arm you. Because believe me, when I went in that first consult, where the orthodontist, and I'm a general dentist, recommended premolar extractions on this child, I called Ben and I called Lauren and they talked to them in a Target parking lot. And they said, okay, this is what you're going to say. You're going to save a life. And my whole life changed. And we can all do that for you. And you guys can all do this. It's not that hard. You just have to be brave and you have to realize that it's so much easier now than it was just a couple years ago. There's a whole team behind you and we are here to support you. And the fact that you guys are on here at night is just incredible. So bravo to all you guys. And we're so grateful to spread the word.
Thank you. So well said. I'm so glad we have these closing statements because everyone's heart's in this. And we know we're here for you as a support team. And we look forward to having you all on Airway Health Solutions faculty in the coming months. So stay tuned from our announcements for that. And thank you everyone for helping us drive this airway health movement forward. We are making a difference and we appreciate your help in that. Have a great night, everybody.